According to the Ontario government, there are 4 moments of hand hygiene. The first being before coming into contact with the patient and their environment. The second being before an aseptic procedure. Third being after body fluid exposure risk. Lastly, after patient or patient environment contact. So there are 2 methods to hand hygiene. The first being hand sanitizer, which is used when the hands are not visibly soiled, and this is beneficial because it's very time efficient. However, the second method is soap and water, and this is when your hands are visibly soiled. According to the best practice guidelines, however, it is most appropriate that antimicrobial soap is used, especially in the hospital setting. Okay, so next I'm going to perform a proper hand hygiene using soap and water. So first you're going to turn on the water so that it's warm, not too hot, not too cold, and you're going to wet your hands. Next, you'll apply soap and rub them from palm to palm. After this, you're going to rub in between and around your fingers. In between, around your fingers. And you're going to rub the back of each hand with the palm of your other hand. And after doing so, you're going to rub the fingertips of each hand on your opposite palm. Then you're going to rub each thumb by clasping with the opposite hand. So after a minimum of 15 seconds, rinse your hands thoroughly under the running water until like all the soap is removed. Once this is done, you can take a paper towel and pat your hands dry. And you want to make sure that you're thorough with this as well because you don't want to spread anything. Okay, then using a paper towel, you can turn off the faucet and you can dispose of the paper towel. Hi, my name is Arda and I'll be your student nurse. I will be following Jane, your nurse, for the next 12-hour shift, and I'll be helping her with her nursing activities. What's your name?
Alex Smith,
Alex Smith. What is your birthday?
January 16, 2000.
Thank you so much. There are 5 vital signs that we look at. First, we'll be looking at temperature. So for temperature, you can take measurements through the oral, tympanic, auxiliary, and rectal options, so all giving the core body temperature of the individual. The average adult normal is 37 degrees Celsius, and that can range from 35.5 degrees Celsius to 37.3. So this temperature is what's ideal for cellular metabolism. When measuring temperature orally, we're going to use a mercury-free glass thermometer. So we ask the patient to open their mouth, and we're just going to place it at the base of their tongue and ask them to clasp and hold it in position for 3 minutes if they don't appear to be physically feverish, but up to 8 minutes if they do appear to be feverish. Once this is done, you can remove it and do the reading. It's also important to note that if the patient has just had a hot or cold beverage, you should probably wait 20 minutes before taking this reading so that you have the most accurate temperature reading. The next vital sign is the pulse, and this is the stroke volume that generates a large force felt at the periphery. And this is important because it indicates the health of the vessels and the general circulation of blood in the body. The average adult at rest will have a pulse of 74 to 76 beats per minute, with a normal range being from 60 to 100. Anything below 60 beats per minute is bradycardia, and anything above 100 beats per minute is tachycardia, and that can come from sepsis. So when you're looking at the pulse, you're going to measure the rate, look at the rhythm as well as the force. There are different arteries that we can use to measure the pulse. There's the carotid, which is up here, radial, which will be in the arm, femoral, which will be in the leg or groin, popliteal, which will be behind the knee. You have the posterior tibialis and as well the dorsalis pedalis. I will be measuring her radial pulse. I will take the pads of my 3 fingers, place them near the wrist until I find the pulse. Once I've located the pulse, I will count the number of pulses that occur in 30 seconds, then multiply this by 2 so that I can get beats per minute. It's not recommended that you do count up till 15 seconds because there's more room for error. The next vital sign is respiration. Normal breathing should be relaxed, automatic, and silent, and this is an indication of a healthy respiratory system. Normal breathing rates in adult patients are anywhere from 10 to 20 breaths per minute. Any abnormalities from this can be an indication of a physical obstruction in the respiratory tract. Because patients can be conscious of their breathing, it's important that this is done, for example, while taking the pulse of the patient. That way they're not aware and they don't try to change their breathing when asked. In order to measure the respiration, you take the number of breaths, that's inspiration and expiration, that occur in 30 seconds, then multiply this by 2. The fourth vital sign is blood pressure, and this is the force of the blood pushing against the vessel wall. Systolic pressure, this is the maximum pressure that's felt after a ventricular contraction. However, diastolic pressure is your resting pressure, and this is felt between contractions. When we take our blood pressure measurements, this is usually a ratio of systolic pressure to diastolic pressure. In a normal adult, this would be 120/80 millimeters of mercury. So I'm going to be demonstrating how to manually take blood pressure. So you're going to need a setup with the cuff. So what's important to note is that the cuff should be appropriate for the arm that you're using. For her, this seems to be appropriate. So which arm do you prefer for your blood pressure?
Left.
All right, so then you proceed to place the cuff on such that the tubes are lined straight down the arm. Okay. Also tighten it so that it's appropriate for the patient. It shouldn't be too tight and shouldn't be too loose. The gauge over here has to be recalibrated a minimum of once a year, so that it points to 0. And you can place that up here while you measure. So the bulb should be tightened to the fullest before pumping. And you're going to use your stethoscope and you're going to feel for the brachial pulse before you begin. So we're going to make sure that the valve on the bulb is fully tightened before we start pumping. Then we pump, and then we slowly release the valve. The first reading where the heartbeat was heard was 119, and the pulse was stopped being heard at 70. So then you can release all the pressure and remove from the arm. So for this patient, her blood pressure was 120/70, which is not too far off from what is considered normal for her age range. So the fifth and final vital sign is pain. The initial assessment of pain involves asking the patient for a description of the pain and getting a better understanding of what's acceptable for the patient. So in order to assess pain, we look at PQRSTU. So first is provocative or palliative, and this is getting at does the pain increase with certain movement or not, the quality of the pain, so getting at the pain mechanism, radiation or the region that the pain is located in, the severity of the pain, the time of onset, or is it diminishing with time, and also an understanding of the pain. So this is getting at previous pain history the patient may have, and so on. So on a scale of 1 to 10, how would you describe your pain today?
2.
During a cardiac auscultation, the patient will be sitting up and will be auscultated underneath the clothing, but for the purpose of this video, it will be over. So there are 4 major sites. There's the second right intercostal space, which will be approximately here. This is indicative of the aortic valve closing. Parallel to this, you have the pulmonic valve that's shown on the left side. On your way down, you can stop at the Erb's point. But once you reach the 5th intercostal space at the lower sternal border, you'll see the tricuspid valve, and then a little bit more subclavically, you will reach the apex or the mitral valve. When we're auscultating, we're looking for the lub-dub sound, which would be in a normal patient, and we're inspecting your S1 and S2. S1 can be found at the apex of the heart, so your tricuspid and your mitral, and S2, this is your aortic and pulmonary, are found at the base of the heart. When listening to abnormal sounds or murmurs, you turn your patient on their left side so that there's almost a shift, and you can get a better listen at the apex of the heart, which once again is here. You're listening for any abnormalities in S3 and S4 as well. So while the patient is taking deep breaths, you start auscultation at the apex of the lungs, which should be above the clavicle, and you move in a Z shape so that you can compare bilaterally. You move down to the 2nd intercostal, the left, the right, then down to the 4th, and so forth. Then mid-axillary at the 6th intercostal space, deep breath, cross. So there are 10 landmarks to be auscultated posteriorly. You can ask the patient to lean forward slightly so that you can reach lung sounds better. Now, so you're paying attention to things like pitch, duration of inhalation and exhalation, and at each location, you are listening to inspiration and exhalation. You can start at the top, right above the scapulae, and move in a Z shape once again. Then you go down to C7, same thing on the other side, further down, breathe, okay, further down. When assessing the abdomen, after inspection, auscultation should be done before palpation and percussion. This is because percussion and palpation can create or stimulate other bowel movements and not give the appropriate observations. So when auscultating, you start at the lower right quadrant. You're listening for a minute, and you should hear anywhere from 5 to 30 bowel movements. If you do not, you have to listen to in that same location for 5 minutes. So you proceed to the upper right quadrant, upper left quadrant, lower left quadrant. So percussion is tapping the person's skin with short, sharp strokes to assess underlying structures. So first you percuss lightly in the same pattern as we did with auscultation of the abdomen, starting at the bottom right quadrant, working your way around the quadrants clockwise. We're listening for tympanic or dull sounds. Tympanic sounds should predominate because in the supine position, the air will travel closer to the surface. Dullness can be an indication of a distended bladder, adipose tissue, fluid, or mass. Palpation is another tactile assessment, and there are 2 types. Light palpation involves pressing your fingers about 2 centimeters deep, and you're feeling for rigidity, lumps, and masses as you move through the quadrants in clockwise rotation. Do you feel any pain or tenderness?
Nope.
Next, we do deep palpation. So you can use 2 hands, and you're going 4 to 5 centimeters deep in the same type of pattern. And again, you're feeling for rigidity, lumps, and masses.